Hello, I'm Justin Waring, and I'm going to be talking about my This Fellowship that investigated the spread and implementation of a new model of care called the Perioperative Care for Older People Undergoing Surgery, or POPS. My presentation and the study looked at the challenges faced in implementing this new model of care, and it identified some of the key strategies that clinical leaders used to get this new model of service implemented into routine practice. As well as providing learning about POPs itself, I think the piece of work and the presentation develops learning for other people looking to implement improvements in health and care services. It identifies common strategies to deal with common challenges. And I think if we think about trying to implement healthcare improvements, there are lots of different barriers and challenges that get in the way and make improvement difficult. There's a huge literature in this area that talk about the barriers to change. So these range from broader social, cultural, institutional factors, right down to the individuals and their skills, their capabilities and beliefs. And it's often, and it's more often the case, that it's a combination of these different factors that are at play and at work. And when we're thinking about implementing improvements, we need to attend to the interaction between these different factors and look at how they complicate change. So for my fellowship, I was interested in the implementation of POPs and the challenges that the clinical leaders were facing and tackling when they were implementing this new service model. To give some more context, POPs developed as a new service model out of growing recognition that older people present a growing portion of people undergoing surgery. And as well as their surgical pathology or the thing that they need surgery for, these older people tend to present in the hospital with other comorbidities. They tend to be older, frail, they have cognitive decline, and other health conditions that impact upon their health. Now, these together can actually impact their post-operative complications, how well they survive and get through surgery, how well they recover after surgery. And so the POPs model was developed to more fully integrate the expertise of geriatricians into the surgical pathway. And this model uses something called the Comprehensive Geriatric Assessment, the CGA. And this is a kind of tool for assessing an older person's broader, more holistic health and well-being needs. And through making this assessment, geriatricians working with the surgical and anaesthetic team can better prepare and plan and support the patient in advance of, during and after surgery to optimise their surgical recovery. Or in some cases to make the decision that actually surgery probably isn't the best course of action for this person. So it's a new model of care that involves geriatricians integrating into the surgical pathway. So we identified three common problems. The first was around staffing issues, and this was about ensuring there was enough people, particularly geriatricians, to provide the service, but it also included other clinicians like nurses and healthcare assistants. The second was around resourcing issues, which again was about linked to the staffing, but providing there were enough clinics, resources, IT support to deliver the service. And the third, and probably most important, was about integrating this new service model into the existing surgical pathways so that geriatricians could work as a team with anaesthetists and surgeons. So we looked at how these problems were addressed and tackled by clinical leaders across different sites. And the research involved case study research with 6 different NHS organisations and looked at how they addressed these barriers to improvement. We draw it together in the research through this diagram that identifies a whole range of key activities in the middle. And these might be summarised around leadership, engagement, evidence and embedding. And we'll talk more about these over the next few slides. So one of the core sets of activities were around leadership, communication, engagement and evidence building. In implementing POPs, it was really important to have credible leadership from the geriatricians. They were there to champion the service, to engage different stakeholders, to build the evidence, and they often acted as project managers, business development managers, communication managers. They were almost kind of small teams running this whole revolution in the way in which surgical care was being developed. Key to what they were doing was around communication and engagement. And this worked in two ways. At one level, it was about national level communication engagement. So working, for example, with professional bodies, policymakers, research institutions to communicate the importance of the issue and the opportunities and benefits of POPs. At the local level, it involved developing tailored communications to target the key issues and concerns faced by local stakeholders, particularly surgeons and anaesthetists. This often focused on, for example, mitigating the wider health risks for older people undergoing surgery, or for alleviating some of the workforce pressures on surgical wards. And the third set of core activities related to evidence building to demonstrate the utility and value of the new POPs model. This involved, for example, using national and international data sets to demonstrate that there was a significant problem in this regard. Using routine service data from within pilot sites to demonstrate that where POPs had been introduced, there were improvements in things like length of stay and surgical outcomes and reduced readmission. And also working to build a new evidence base through carrying out new research, audits, trials, and improvement studies, all of which came together to demonstrate the value of the POPs model. So these provided the kind of core activities, but they were manifest through two particularly important engagement activities. The first was around professional engagement, and this was really about working with surgeons and anaesthetists to really communicate the value and benefit of POPs. And this was often targeted at their concerns around risks, particularly the risks that older surgical patients bring to the care process, and those things that are often outside of the expertise of surgeons, for example, related to the person's wider holistic health and well-being needs. It also involved aligning the POPs model to national audits, particularly NELA, and showing that where services had a POPs model, they actually did better in national audits. And again, it involved demonstrating the actual tangible benefits to surgical outcomes and things like length of stay and supporting things like discharge. But they also talked about the importance of what we might call soft skills, working with surgeons and surgical teams over the long term to persuade them of the benefits in POPs, and ideally to bringing those surgeons into the POPs team as champions and flag bearers to demonstrate that this is a good thing to do. On the other hand, the clinical leaders engaged in a lot of working with managers in their local trusts and organisations. Again, what we saw here was a targeted focus. Here instead, though, it was about things like length of stay, throughput and costs, demonstrating that POPs could actually have operational benefits and value to the service. It also involved building a business case that demonstrated the return of investment and using all the different evidence sources to demonstrate that POPs could work. When put together, these led to three kind of important developments across the different service sites. The first we call operational integration. So POPs in many ways became incrementally integrated into the surgical pathways. And in many sites, the surgeons themselves became the champions for POPs, advocating with managers the need for further investment in geriatricians to support their surgical pathways. Where these worked nicely together, we saw sustained funding. So managers and surgical leaders did provide the additional resources to provide and grow staffing for these POP services, based upon, for example, cost savings and performance improvements. And the third thing we identified was this shift towards more distributed leadership. So more clinicians, and not just in the geriatricians, but in surgery and the anaesthetics, started to become the champions for the POPs model and really promoting and trying to develop it in their own services. When we think about how improvement happened, and this is largely informed by normalization process theory, we identify four key strategies. The first is around tailored communications that help people make sense of change so they can understand what's going on. The third is around communication strategies that focus upon the legitimacy of change, and so that people think it's the right thing to do. And the third thing is around local adaptation, so that change can be tailored to what's already going on rather than being forced upon service providers. And the fourth is about using evidence to demonstrate change and sustain change over a longer term. So I hope this has been useful. And if you want more information, please click on the QR code to read the full paper. And have a good day.